Hi everyone, welcome to ECG Tips and Tricks Video B Clinical Cardiology Dr. Game. Ventricular tachycardia, VT or not VT? That is the question. Before we start, here are a few things you must know about VT. 70% of regular wide complex tachycardia is VT. History of MI, structural heart disease, or old age makes VT even more likely. No single ECG feature is diagnostic of VT. Presence of any 6 of ECG feature of our ABCDEF approach is highly specific for VT, 90 to 100%. Number 1. A is for axis. Is there an extreme axis deviation, also known as northwest axis? Presence of a northwest axis, -90 to -180 degrees, is highly specific for VT, 90%. Look for a dominant R wave in lead AVR for quick reference. Dominant R wave in AVR, dominant S wave in lead 1 and AVF, that's extreme axis. Please also always consider metabolic disturbance, as electrolyte imbalances can cause similar changes in ECG. Number 2. B is for broad complexes. Use a cutoff of greater than 200 milliseconds, which has a specificity of 85 to 90% for VT. Below this, there is too much overlap between VT and SVT with aberrancy. Number 3. C is for concordance. If it was possible to make diagnosis on a single question, this would be it. Does the QRS complex resemble any form of aberration? If so, think of SVT, if not, then it's VT. Precordial concordance, a lack of RS complex in V16, is 97% specific for VT. Positive concordance refers to entirely positive complexes. In lead V16, with no RS complexes seen. Negative concordance is entirely negative complexes. QS, complexes in V16. Number 4. D is for dissociation. Is there AV dissociation? Any evidence of AV dissociation is highly specific for VT. P and QRS complexes at different rates. Capture beats, where the SA node transiently captures the ventricles, producing an isolated normal QRS complex. Fusion beats occur when a sinus and ventricular beat coincide to produce a hybrid complex. Number 5. E is for early part of QRS. Is the early part of the QRS fast or slow? VT propagates from ventricular muscle, with initial slow myocyte to myocyte conduction time. This causes a delayed or slurred initial QRS component. In VT, time to peak of depolarization. That's R wave is often delayed at greater than 40 milliseconds in V1 or V2. Number 6. F for fragmentation of the S wave in V1. A notched S wave in V1, otherwise known as Josephson sign, is another highly specific sign of VT, 97 to 100%. It is a fragmentation of the nadir of the S wave, probably caused by fibrosis due to previous infarctions. Here are a few minutes of knowledge. Please like this video, follow us more and share. See you in next video.